Okay, chapter 11, venous insufficiency. Last week we learned about arterial insufficiency. This week we're going to go over venous insufficiency. So the objectives for chapter 11 are to differentiate the etiology of venous insufficiency ulcers, to describe and choose physical therapy tests and measures to assess patients with venous insufficiency, to compare and contrast the typical characteristics of venous and arterial insufficiency ulcers. So we want to be able to understand what does a venous ulcer look like versus what does an arterial insufficiency ulcer look like. We again went over the arterial insufficiency, so this week we'll talk about venous, and they are very different. The way they look, the way they present, characteristically, it's difficult to think that it's an arterial insufficiency when it's a venous insufficiency, because they're very different in how they look. So we're going to select physical therapy procedural interventions for patients with venous insufficiency ulcers, including integumentary repair and protective techniques, physical agents and modalities, and therapeutic exercise. And then we're going to describe the therapeutic effects and contraindications for compression therapy in patients with venous insufficiency ulcers. There's 3 different films that go with this, so I will attach these so that you guys can see them. One of the things that's really important as we go through this chapter this week, you will see is it's absolutely imperative. If it's a pure venous insufficiency ulcer, it's absolutely imperative that you use compression as a part of your treatment. Now, please hear me say if it's a pure venous insufficiency ulcer. The reason I'm saying that is if there is arterial insufficiency as well, we've already talked about, you should not be using compression. So there are people who have a combination of arterial and venous insufficiency. So you have to be very aware of that when you're considering compression. All right, so the prevalence of venous insufficiency, chronic venous insufficiency, is about 10%, 9.4% of the population, but 70 to 90% of the leg ulcers that are seen in the public is due to venous insufficiency. Okay, so there's a very high rate. The prevalence of chronic venous insufficiency is only about 10% or 9.4% of the population, but those that do have venous insufficiency usually have leg ulcers, so you see a lot of leg ulcers that are due to venous insufficiency. Women have a 3 times greater risk. Generally, the reason for that is because of childbearing, weight. As we get to how the venous system works, you'll begin to understand how childbearing and excessive weight can cause venous insufficiency over a period of time. So that's why women do have a 3 times greater risk of venous insufficiency than men. The risk of a venous insufficiency ulcer is 7.5 times greater after age 65. Again, as we get to the mechanics of what causes venous insufficiency, you'll understand why that is also the case. So the rate of reoccurrence rate is 13 to 81%. And that is directly correlated with non-adherence. We've already talked about the treatment for this is compression. So if someone is not, if they heal up and you put a compression, you order a compression stocking for them or get them compression stockings, if they do not wear them, they will have another ulcer. So that recurrence rate, the reason it is so high is that there is a large non-adherence with wearing compression garments. All right, here's a quick picture of the venous system, the veins, and as we get into the lower extremity, you have a superficial and a deep venous system. So what you're seeing here is more of the deep system. We're going to go a little bit later into the superficial system as well. So let's just talk a little bit about the venous system overall. It is a low pressure system. What does that mean? That means that when you talk about, in comparison to the arterial system, so when we talk about if there is a rupture of an arterial, an artery, you see spurting, right? You see the blood coming out under very high pressure, so there's actually spurting of the blood. You will not see spurting coming out of the venous system because there is no pressure behind it. It is a very low pressure system. The venous system, though, does store 70 to 80% of the total blood volume. So at any given time, that means there's only 20 to 30% running through the arterial system, because the arterial system, as you guys remember, has a muscular layer. The venous system does not have a muscular layer. There is not a propulsion to the blood going through the venous system. The veins do have the same 3 layers of the artery, but it has smaller amounts of smooth muscle, as it says right here. It is very much thinner, and it has less connective tissue support. So that smaller amount of smooth muscle does not create the force that you get with the arterial system or the arteries. This is what I was talking about as far as the anatomy of it. The deep veins are the femoral, the popliteal, the tibial, and they carry 80 to 90% of the blood back to the heart. Then you have the superficial veins, which are the greater and the lesser saphenous, and they actually drain the skin and the subcutaneous tissues. These are the ones that assist with temperature regulation. And then the perforating veins are what goes in between the deep and the superficial veins. So they run perpendicular between the deep veins and the superficial veins to communicate between the two and carry blood from one to the other. Here's a close-up of the lower extremity veins. Something that's really important for me to show you is this. These valves are really important when we start to talk about venous insufficiency and incompetence, venous incompetence, okay? So here's the larger view. We go from vein to venule to capillary, just as on the arterial system, we went from artery to arterial to capillary. We do the same thing with the vein. But the structure, again, notice it's very much thinner than the artery, and within the vein we have these valves, and these valves become very important when we talk about venous insufficiency. All right, so the proximal flow of venous blood, so getting it from distal to proximal, relies on the respiratory pump, the calf muscle pump, and the valves. I said it just last slide, those valves become very important when we talk about venous insufficiency, and so we'll talk about that a little more detail. So the respiratory and the calf muscle pump is such that distally, when you pump the calves, the valve opens. There's a movement of the blood, and it goes from one section to another. So what they're trying to show you here, okay, so here's a valve that's closed, all right? So there's the fluid that's in here is forced by the pump of that calf muscle, is forced up out of this valve. So there's movement of the blood out of this valve. Well, this one is closed, so it can't go lower. It can only go higher. And so once the calf pumps that blood out of this section of the vein, it goes up into the next section of the vein. This valve will close off so that the blood is in this section of the vein, and then again is then pumped up into the next section. So that's how the blood is pumped from one section of the vein up the leg into the greater veins, okay? By the same token, once it is in the vena cava, which is the larger venous system, the respiratory system, or the respiratory pump, as you breathe in and out, it creates a pressure gradient from this vena cava that forces the blood up into the heart. Okay, so that's how the diaphragm and the intercostal muscles, the thoracic cavity, as you breathe out and in, creates a pressure gradient that forces this blood up into the heart. So what happens with venous insufficiency? So first of all, with venous insufficiency, you have a sustained venous hypertension. What does that mean? Well, what does hypertension mean? Hypertension means a high blood pressure. Within the venous system, you have a high pressure of blood. Remember, we just talked about in the deeper veins, it said that it was 70 or 80 to 90% of the blood is perfused through those. So if you have that much blood in it in the venous system, you have a high risk of having a large volume, which creates that hypertension. Some of the common causes of the venous insufficiency are a vein dysfunction or a calf muscle pump failure. So vein dysfunction comes from those valves becoming incompetent. And what I mean when I say, when the term incompetent is used, means that they no longer close sufficiently, so they leak. So instead of holding that amount of blood in that section of the vein, that valve leaks, and some of that blood will flow back down, because think about gravity is going to pull it down distally. If it is not closing directly, then it's going to pull it down distally. So the reason for some of this, the fibrin cuff theory says that the fibrin creates creates damage to those valves. Then there's also the white blood cell trapping theory, but likely what happens is a combination of both theories that causes this venous dysfunction and the calf muscle pump failure. So, as I said about the incompetent veins, you see here a normal vein, as we just talked about. This is closed. There's fluid in here. This top one opens and it pushes the blood up to the next compartment within the vein. So that's how it moves up the leg. But with an incompetent vein, it does not close completely. So blood flows down. Being pulled down by gravity. And that's when you see things such as these large blue varicose veins that you do see sometimes on people out in the public. But that is the cause of venous insufficiency. So, with factors contributing to venous insufficiency ulcers is a vein dysfunction. You get the venous hypertension, you get valve damage, there's degeneration of the valve, there's scarring, inflammation, you can get clots within the valve, within the vein, and then you get the varicosity, which is the very large blue distended veins that you see in the legs. So here's the cycle of venous hypertension. So what happens is you get the pooling of the blood, or the venous hypertension. Then you get a retrograde venous flow. Remember I said if the veins become incompetent, the blood goes back down. Gravity pulls it back down. Once it pulls it back down into those lower veins, those veins get distended, which causes even more of a hypertension, because you get a more pooling of more blood, which causes a higher level of venous hypertension. With the calf muscle pump failure, I think we talked about this maybe in class. One of the things that we know from manual muscle testing is that for a calf muscle to be considered normal, someone has to be able to go up on their toes 25 times for it to be considered normal manual muscle test. Well, most adults cannot do that. So you have a calf weakness or paralysis. You have a decreased dorsiflexion because of prolonged standing and incompetent valves. You get a calf muscle pump failure. One of the other factors that contributes to venous insufficiency ulcers quite a bit is a trauma to a venous insufficient leg may result in ulceration due to edema-induced local tissue hypoxia. So what I mean by a benign trauma is we've talked about this venous hypertension that's going on. So you have these very large swollen legs, and if something happens to hit that leg, it can burst, literally burst like a balloon that's got too much water in it. It can literally burst that skin, and then you get an open wound or a venous insufficiency ulcer. So, people with a previous venous insufficiency ulcer, as we talked about earlier, recurrence rate can be as high as 81% because they're usually non-compliant with the treatment. There's local tissue hypoxia and malnutrition. Again, there's such a hypertension there. I know this sounds weird because you think, well, there's a lot of fluid down there. So why, and there's a huge pooling of blood, so why is there hypoxia? Because the pressure, the amount and force of the amount of fluid down there exerts so much pressure that it actually causes tissue hypoxia and malnutrition because the blood can't perfuse due to the amount of pressure within that system. There's can be scar tissue from prior ulcers, which increases the risk of skin breakdown, as we've already talked about. The tensile strength of the skin, once there has been an open wound that is healed, the tensile strength is never as strong. And then participating factors in wound etiology are not successfully addressed. So precipitating factors such as maybe they're a smoker, maybe again, there was compression issues. There was not adequate compression. So if that stuff is not addressed appropriately, then you get it right back again. You get wounds again without addressing that. All right, advanced age. So when we talked about the incompetence of the veins, you can imagine, or the valves within the veins, you can imagine the longer we are on this earth standing upright, the greater, the more pressure that's on those valves. So as people get older, there becomes a natural incompetence of those valves because of the length of time basically that the valves have had to work going against gravity. So anatomical and functional changes that occur with aging, such as generally an increased weight, increased pressure on the legs, decreased exercise, so that you get that decreased pump efficiency of the muscle. So in other words, you don't have the natural anatomical assist that you had when you were younger from the muscles around it, just because the veins themselves age, and then the muscles, again, you see decreased strength and proficiency of the muscle pump, and so the valves do degenerate with advanced age. Also with diabetes, you'll see increased microvascular disease. I think we talked about this when I was on campus. Diabetes actually causes the very small capillary, at this very small arterial, venual, and capillary level, causes significant disease at that very small level. There's an impaired immune system or response with diabetes. It takes longer to heal, and as we've talked about, it impairs all three phases of wound healing: inflammatory, proliferative, and remodeling. So what do we do? What kind of tests do we do for venous insufficiency? Well, we do a clinical assessment for DVT. You guys may remember the Wells test that can give us a good idea. It has really good specificity and sensitivity for DVT. We can do an ankle brachial index. We can do the Trendelenburg test, and we can look at venous fill time. for as far as a clinical assessment or what test they would have in a hospital, the venogram is the gold standard. So they can be sent down to the vascular labs, and they can do a venogram to tell us what the veins really like. A lot of times they'll do an ultrasonogram because it will tell us what the veins look like. They can't really use this for screening because it's really kind of expensive. If you think about tracing each of the veins, there's a lot of veins, and if you think about tracing the veins within the legs, both legs, it's really kind of, it's very sensitive, and as it says, there's a lot of specificity there, but it's really too expensive to use as a screening. So we also, I think, talked about this where Homan sign. You guys remember if you quickly dorsiflex the foot and there's pain in the calf, that's Homan sign, and it's said to be a risk for a DVT, but in research it has been shown to have a really low sensitivity and specificity. So we want to do the clinical, follow the clinical assessment guideline for DVT, which is using the Wells survey, the Wells outcome tool, which will give us is so much better, so much more highly sensitive for DVT. But once you know that there is a DVT, or when you see lower leg ulcers, lower leg edema, you really want to suspect a DVT, and you really want to do a Wells test on them, because when you see this edema and these ulcerations, you know there's a pooling of blood, and when you see that pooling, you can suspect that there may be clots or DVTs formed. Okay, so here is the Wells assessment. Okay, clinical assessment guideline for deep vein thrombosis. Again, Wells was one of the authors of it, so it's often called the Wells assessment because he's done it. I think put another one out. But anyway, so what you do is you're adding points based on clinical signs or symptoms that the patient may have, or history. Okay, we've already talked about the ABI. You guys know how to do that. As I said earlier, the arterial and venous insufficiency coexist in about 15% to a quarter of all lower extremity ulcers. So you have both, which is why the ABI is so important. If the ABI is less than 0.7, you really don't want to do compression. I have done it in the past, but I watched them very, very closely, and the compression was, how do I say? It wasn't as tight as I would do. I would do a wrap that wasn't as tight as a normal compression if the ABI was that low. And again, I watched them very closely, and I don't do the compression for the number of days that I would normally do it if I know that somebody has a low ABI. You do want to repeat the ABI pretty regularly, perhaps every 3 months, because there can be changes in it. Obviously with someone who's got peripheral arterial disease, you really want to, as it advances, you really want to make sure you stay on top of it. So the indications are if there's a lower leg ulcer, or you suspect arterial or venous insufficiency, but you don't want to do an ABI if you suspect a DVT. Again, you don't want to blow that cuff up on the lower extremity if you already expect that there's a clot there. The Trendelenburg test is when you put them in supine with their legs in 45-degree elevation for 1 minute. You look at venous distension, and then you put a tourniquet to the distal thigh and you stand them upright. You note the time for superficial venous distension to occur, and then you release the tourniquet. The indications for this are to differentiate deep or perforating vein incompetence from superficial vein incompetence. So here's the interpretation of the Trendelenburg test. So once they have the tourniquet, when you stand them and put that tourniquet on them, you will see the veins distend in less than 20 seconds or less, which suggests that maybe you have a deep or perforating vein incompetence. Once you remove the tourniquet, if you see a venous distension within 10 seconds or less, you will know that's a superficial vein incompetence. Remember, when we talk about the superficial versus the deep, it's where it lies within the anatomy of the lower extremity. All right, Doppler ultrasound is where you do the ultrasonogram we talked about earlier, and it is the gold standard for the venous system. More subjective than the arterial Doppler. They do a resting test, an augmentation test, and a reflux test. And so each of those tests tell us is what the veins look like at different points, like when the person's in different positions, or the person's resting, or the person's moving, like standing. That's what each of those different tests tell us. And the indications for the Doppler ultrasound is to differentiate normal venous flow from incompetence or obstruction. Venous fill time is a predictor for arterial insufficiency. You put the patient supine, you note the superficial veins on the dorsal foot, elevate the limbs 60 degrees for 1 minute until the veins are drained by gravity. Then you put the lower limbs in a dependent position, and you know the time for the veins to refill. We talked about this previously. The indications are, if they're unable to tolerate the ABI, you can't do an ABI on them, or if the ABI is greater than 1.1, which, as we talked about, a lot of times if they have a history of diabetes or vessel calcification, so that you can't, when you do the ABI, you can't squeeze that artery because it's calcified, you will get that higher ABI. So that's when you want to use venous fill time, or if you suspect concomitant arterial insufficiency. So in other words, you've got someone with venous insufficiency, but you suspect that they also have arterial insufficiency. So here's the interpretation of the venous Doppler examination. And this just tells you when they suspect venous obstruction or partial or valve incompetence. So there are some classifications that are used for chronic venous disease. I have not seen them, quite frankly, used a lot in medical records, but please read up on these in your reading. So here's the classification system for the chronic venous insufficiency. A CO is asymptomatic. A C1, you can see spider veins that are smaller than 3 millimeters when you do a physical observation or examination of the leg. When a C2 is if you see varicose veins that are greater than or equal to the 3 millimeter veins. If they have, in addition to seeing, the spider veins or the varicose veins, you also see leg edema, they would be considered a C3. A C4 is when there's subcutaneous and skin changes. So C4A is with hemosiderin deposition, meaning that they actually have the discoloration, like this reddish purple discoloration that you'll see in the lower, around the ankle, right above the foot that goes up to mid-calf. That's called hemosiderin staining or deposition, and that would be a C4A. It comes from hemosiderin is the chemical that gives the red blood cell the red color. And so because there's such a pooling of it in the lower leg, the hemosiderin actually, there's such a pooling of blood, the hemosiderin actually starts to stain the skin. It's deposited within the skin. So that's why that's a C4A. And then a C4B is lipodermatosclerosis. I can never say that word. Anyway, So what that means is that with someone who has a chronic venous insufficiency as a result of a large amount of obesity, you'll actually see sclerosis of the skin. So it starts to get very elephant-like, if you will. So it looks very tough, and that shows you that there's not getting the perfusion that it needs, that there's there's a chronic venous hypertension there, which is causing this lipodermatous sclerosis. They're a C5 if they have an old healed venous ulcer. They're automatically a C5 within this classification system, and if they have a current venous ulcer, there's C6. So just like we did with the arterial ulcers, with the venous ulcers, we're going to look at pain, position, presentation, peri-wound, pulses, and temperature when we look at the venous ulcer itself. So when you compare a venous and arterial insufficiency ulcer, you want to look at the amount of pain. With an arterial insufficiency ulcer, remember we talked about the amount of pain they would have with movement would be severe. And then it would increase with elevation. With a venous insufficiency ulcer, the pain will be mild to moderate, and it'll be decreased with elevation and compression. The position of a venous ulcer will be on the medial malleolus or the medial lower leg, or any areas of trauma where the leg has been hit. An arterial insufficiency ulcer you will see on the distal toes, the dorsal foot, or again any areas of trauma where it may have busted it open. The wound presentation. A venous wound presents very irregularly shaped. It's red, it's ruddy, it's a very, very red, beefy red wound bed. It's got this glossy coating on it, and it has tons and tons and tons of drainage. So let's think about this. We talked about a venous hypertension. If I have a venous wound that's open, all of that pressure from all of that fluid is going to cause copious drainage from that open wound. So that's a venous wound. Whereas a arterial wound has a very regular appearance, meaning, remember I talked about punched out look, so it's a perfect circle. Looks like somebody took a hole punch and just punched it out. Very regular, uniform appearance. It may conform to trauma. You're going to have very pale granulation tissue because you don't have a lot of blood flow. You're going to see black eschar. You're going to see gangrene, and you're going to see little or no drainage because, again, there's not a lot of fluid getting down there. So the peri-wound and structural changes you'll see with venous insufficiency, you see a lot of edema, cellulitis, dermatitis, hemosiderin deposition, and dermatosclerosis. I'll get it in a minute. With the arterial insufficiency, you're going to see no hair growth. You're going to see thick yellow nails, and the skin's going to have a pale, dusky, cyanotic, like almost blue look to it because there's not a lot of perfusion. And again, you'll see black eschar. With the pulses, with the venous insufficiency, your pulses will be normal. Okay, if they're decreased, it's due to the large amount of swelling, or if they've got an arterial insufficiency as well as venous insufficiency. With an arterial ulcer, though, you're going to see decreased pulses, decreased to absent. You may not be able to see feel pulses at all with an arterial insufficiency ulcer. The temperature for venous insufficiency ulcer is going to be normal to mildly warm. Again, you've got a lot of fluid down there, so it's either going to be like a normal temperature or maybe slightly elevated warmth. With arterial insufficiency, because you don't have a lot of perfusion, there's going to be a decreased temperature. Here is a venous insufficiency ulcer. You can see that it's a very irregularly shaped wound. It doesn't have a punched out look. It doesn't have a circular look. It's very irregular. we've seen this so many times. I'm not sure why they've used this picture as much as they have, but this is an arterial insufficiency. It's in the inflammatory phase of wound healing. Okay, there's a lot of edema around it, so and the thin yellow, the thin layer of yellow slough. So this is an arterial wound. So the healing time for a full thickness venous ulcer with appropriate interventions is 8 weeks. If it's a small ulcer, it can be 5 to 7 weeks, but if it's a larger ulcer, it can be 10 to 16 weeks. That's if the patient is compliant and there are appropriate interventions such as compression. So if there is a small chronic venous insufficiency ulcer, then you, with good healing, no deep vein involvement, and adherence with compression, you can see it start to decrease within the first 2 to 3 weeks of treatment. However, if you have someone that is not healing well, they have a larger size chronic venous insufficiency wound, they also have peripheral artery disease, so they have some arterial insufficiency, they're going to be older and have a higher BMI, so they're going to be fatter, more obese. You're going to see a poorer healing rate, and you're going to see their increase in size over the 4 weeks of treatment. It will get larger. Gender, race, skin condition, and presence of infection has not been shown to be predictive of chronic venous insufficiency healing. So these 4 things are not predictive of healing with a chronic venous insufficiency ulcer. What is physical therapy intervention? Well, the PT services must be coordinated with the patient and the caregiver and all the other disciplines, as we've talked about before. You're going to be working with nursing and your MD and all the other disciplines when you're doing wound care. You're going to address the etiology and the risk factors as you are able. We did talk about the calf muscle pump failure, so you're going to be looking at strengthening, range of motion, those kind of things as you can with the patient. So you want to educate the patient about how this happened, what's going on with their veins, why do they have these wounds, explain why. When you explain what's going on with their veins and why they have these wounds, then you can also link that with why you're having to do compression, because it should make sense to them once they understand the nature of the wound, why compression is one of the treatments. You want to talk to them about the risk factors for ulcerization if they aren't compliant with that compression. And then you want to make sure that you understand how they think about adherence and outcomes, and if they think it's going to make a difference to maintaining the health of their lower extremities. So you want to provide them guidelines like how do you control the swelling, protect your feet and legs from trauma. We've talked about living healthy means a good nutrition, well hydrated. You want to educate them on knowing when to call the clinician. So when does it look like? What are the signs and symptoms of infection is when they should call in a clinician, or when does it, if the wound looks like it's getting worse instead of better, that's when they should call a clinician. And then you also want to talk to them about proper positioning and exercises to enhance venous return. Well, what are some of the exercises to enhance venous return? Again, it would be related to calf muscle or muscle pump. So what are the precautions if they have arterial disease along with the venous insufficiency, if they have any allergic reactions or they're sensitive to any of the procedures that you're doing, or inappropriate whirlpool use? Again, I think we talked about during modalities when I did the lecture on modalities. This is very a venous insufficiency ulcer is very wet. There's absolutely no reason to put them in a whirlpool in a dependent position with their legs hanging down. So first of all, you're increasing the edema because you're putting them in a dependent position, and you're putting them in a wet whirlpool when it's already a very wet wound. All right, so when would you want to request further medical testing? Well, if the DVT clinical prediction guidelines tell you that there's a possible DVT, you want to make sure that they get some vascular labs to see if there truly is one. If you're seeing a wound that's not progressing after 2 to 3 weeks, if you suspect infection, if you suspect there's any kind of abscess or anything going on within the bone, or if you have a wound that doesn't present the way a venous insufficiency ulcer typically presents, which is the irregular borders and the very beefy red wound bed. So you want to protect the surrounding skin. You want to make sure that it's, because of the edema, the peri-wound skin can get very dry, because again, think about it. We talked about the venous hypertension. So it's going to prevent perfusion to that. Remember, we talked about tissue hypoxia. So it's going to prevent perfusion, full perfusion to that skin, that outermost layer. So it could be dry and scaly. You want to make sure that you moisturize it and protect it. You can use topical steroids to decrease inflammation or weeping. But you want to use them very rarely because you don't want them to become overly sensitized to those topical agents. So with the wound bed, what do? Well, it's a wet wound. So what are you going to do with a wet wound? You're going to use an absorptive dressing, and you're going to use skin sealants around it to protect that peri-wound skin. You want to enhance venous return by applying compression if you don't have that arterial insufficiency going on as well. And you want to instruct the patient in methods to decrease edema, ankle pumps, elevation, and how to make sure they're using the compression per protocol. You want to educate them again on the wound etiology. What are the intervention strategies? How can you modify risk factors? And what are the guidelines for patients with venous insufficiency ulcers? So you have a patient with a venous insufficiency ulcer. You want to treat the wound. If we go immediately up, you want to control inflammation and infection. You want to absorb the drainage, and you want to debride any necrotic tissue that's there. If we go to the left, you want to treat the cause. Okay, so venous hypertension is generally the cause, and the treatment for that is compression. There can be a surgical intervention if the veins are so bad that they need that, so that can be, but 9 times out of 10 you're going to use compression. Then if we go down to the bottom, you want to always make sure you educate the patient and the caregiver about what they're doing, how the wound started, and what it's going to take to heal it. You also, as we go to the right, you want to address the healthcare team and the patient comorbidities, and then we want to treat the peri-wound. Over on the far right, we want to treat the peri-wound because, remember, these are very wet wounds. So you want to make sure that that skin surrounding it doesn't get macerated and die. Okay, so you want to control infection, absorb drainage, do any kind of debridement if you do get maceration, and you want to moisturize any dry, scaly skin further away from the wound. So these are physical agents and mechanical modalities you can use. We've talked about compression. We want to enhance the calf muscle pump, which improves venous return, decreases peripheral edema, reduces venous distension, increases tissue oxidation, softens the lipodermatosclerosis with compression. So that elephant-like skin that I talked about, with compression over time, it will soften that skin, so it doesn't look like an elephant as long. Compression also protects the limb from trauma, and it limits the need for prolonged elevation or bed rest, which, if you think about it, we don't want them in bed resting. We want them moving around as much as possible because we want that muscle pump. We want them to continue to have the efficiency and the strength of that calf muscle to pump that fluid. All right, so here's the parameters. Generally, with someone who has a venous insufficiency ulcer, you want to make sure that at the most distal part, which is the ankle, there's 30 to 40 millimeters of mercury at the ankle. There's 10 at the infrapatellar notch. If there's severe venous insufficiency with a physician, in most states, a physician order is required to increase the compression parameter to 40 to 50 millimeters of mercury. But if it's very mild, you can decrease it to 20 to 30. So contraindication to compression is an ABI. We've already talked about that. That's less than 0.7. If they've got infection, you don't want to use compression. If there's pulmonary edema, okay, so you say, why would that be a contraindication? So let's think about what we're doing with compression. If we're putting compression on their lower extremities, we're pushing fluid back up to the larger venous system. So we're pushing fluid back into the vena cava, back into the trunk, back into the core. And if they already have a pulmonary edema, they may not tolerate that. So anyone who has pulmonary edema or COPD, I always make sure before I do compression that I call the doctor and make sure that moving fluid out of their lower extremities is not going to overload their lungs or their heart. And so that's what uncontrolled or severe congestive heart failure is the next one. Is just what I was just talking about. If they have an active DVT, you don't want to do compression. And if they have claustrophobia, and this is kind of a weird thing, but when you put compression on people, some people tend to perceive it as being closed up as they get wrapped. They don't like that feeling of the pressure around their legs. So you can have this kind of a psychological overlay where they cannot tolerate compression. So the types of compression, their paste bandage, also known as an Uniboot, is covered with zinc oxide, and so it's a gauze wrap is what it is, but it's covered with a zinc oxide. So it's a very wet bandage that you wrap around the leg, and when it dries hard. You can also use short stretch compression bandages, which you guys have in the lab. You have some short stretch compression bandages. A long stretch compression bandage is what we know as an ACE wrap. A short stretch looks like an ACE wrap, but it is woven a little bit differently. So the reason that short stretch is recommended here is because with a short stretch, it facilitates compression when there's a muscle pump, but it doesn't give prolonged compression when there's no muscle pump. So the venous system works best, and the lymphatic system works best when there's since the short stretch compression bandage is not causing extensive compression when the leg is at rest. There's multi-layer compression bandage systems. Circaid is a kind of compression system that velcros on, so it's easier to take on and take off, because a lot of compression garments are really hard because you've got so much compression. They're really very difficult to get on. A Circaid though has Velcro, so you put it on and literally Velcro it so that it causes that compression. There's tubular bandages if you have just need a lighter compression. Then compression garments, we talked about measuring for compression garments because they can be custom made. And then there's also a vasopneumatic compression device, and these are the pumps. These are the big huge appliances that go on the leg, and they attach to a pump which squeezes the leg. There's a sequential or segmental squeezing of the leg that increases the pressure segmentally and pushes some of the fluid out. So the paste bandages, again, it's gauze and zinc oxide, calamine, glycerin, and gelatin, and hardens to a semi-rigid support. You can keep it on for up to 1 week, and you can use this for ambulatory patients. And that is the example of a paste bandage, commonly known as an Uniboot. That Coban, that brown wrap that you see around the bottom, you have to apply to the dressing. Otherwise, that zinc oxide will get on their clothes, it'll get on their sheets, it'll get on everything. So you apply that Coban to keep that wet paste from getting on everything that the patient owns. The disadvantages is it does smell, it has an odor to it. That zinc oxide has an odor to it. You cannot shower or get it wet. It causes severe sweating, and sometimes there's some there can be some infection caused with it. You can't use it in areas of high humidity because it won't ever dry. It just stays sticky. And once it does dry hard, if the limb gets smaller, significantly smaller, or swells, it's going to really hurt that patient because once it dries, it doesn't accommodate to changes in the limb size. Short stretch compression wraps, again, has a lower resting pressure than what we commonly know as an ACE wrap. It doesn't, when the calf muscle pump is working, it assists the muscle pump. When the muscle pump is at rest, it doesn't create extensive compression. You can use this on ambulatory and non-ambulatory patients. So the amount of compression is determined by Laplace's law. Dr. Bauer talked to you about Laplace's law, but basically what you need to know is there's enough compression to reduce the edema without causing, there's so much pressure that or compression that you're cutting off the flow of the blood. The disadvantages is that it can slip, meaning that the patient, you probably have to teach the patient how to rewrap themselves. So they have to be trained in how to rewrap themselves just in case the bandage does slip. This is the long stretch versus short stretch film that will show, let's see if I can show it here.
Long stretch bandages, such as the typical ACE-type bandage, are highly elastic. They have a high resting pressure, which may limit circulation while a patient is stationary. They have a low working pressure. Short stretch bandages have a low resting pressure and little distensibility, making them comfortable and preventing them from restricting blood flow. Short stretch bandages have a high working pressure, making them capable of enhancing the effect of muscle pumps by creating a fixed volume container.
Okay, that worked. So this is Laplace's law. So the bandage compression is equal to the tension, the layers applied at a constant over the girth of the limb and the width of the bandage. With a short stretch compression wrap, you may need to pad around the bony prominences, such as the malleolus, just because as you're wrapping compression, when you've got just bone, skin over bone, you have to protect those areas. So you use a spiral or figure of 8, which we worked on in the lab, and you use, depending on what product you use, they will have directions for how you apply the tension. I think I showed you there's usually yellow markings on them so that you can know how far to go with the short stretch. When you have a compression bandage system, which is a multi-layer, there's usually an inner layer which is kind of like cast padding, that will not only absorb the wound drainage, because remember these are very wet wounds, but it'll also provide padding like we talked about around the bony areas. The middle layer also absorbs drainage, and then the outer two layers provide increased compression. The compression bandage system is reusable and can accommodate for unusually shaped limbs, stays in place better, and maintains compression longer than the short stretch wraps alone. So when you use a multi-layer system, it does stay in place better. So this is a multi-layer compression bandage. So A that you see right here, this is the padding, or it's like cast padding. So you're padding the leg with A. Then with B is a conformable bandage. This again is also used for wrapping the padding. So when there's a draining wound, the drainage would be taken up by not only this padding on this first layer, but also this conforming bandage on the second layer. And then C begins your compression layers. And these marks are what I was talking about that tells you how to wrap it. So you wrap, when you're doing the figure of 8, you wrap to each of these lines. As you come around, you wrap to that line. So that's the light compression, and then this is a cohesive bandage, like a co-band, like that brown one we saw earlier, kind of sticks to itself, and that's the outermost layer, which also provides some compression.
In this example, cotton padding is applied from the metatarsal heads to the bend of the knee. Layers of padding are applied superior to the patient's ankle to transform the limb into a cone shape, eliminating a local increase in compression caused by a narrower ankle. The padding also more evenly distributes compression. With the patient positioned in full dorsiflexion, a 10 cm short stretch compression wrap is anchored at the metatarsal heads, and a figure of 8 is made around the patient's ankle and foot. The bandage is then spiraled at an angle up the leg, maintaining even spacing between turns. The clinician should maintain consistent tension and avoid wrinkles. A second wrap of the same width is spiraled up the leg to the bend in the knee. If less compression is desired, a slightly wider bandage can be used. Assuming no changes in tension, bandage width, or bandage overlap, a figure-of-8 compression wrap provides greater compression because more layers of bandage are applied to the limb. A self-adherent elastic compression wrap, such as Coban or Coflex, can be applied over either a spiral or figure-of-8 compression wrap to provide added compression and help prevent bandage slippage.
All right. Circ8, I've already talked about a little bit to you. Semi-rigid orthotic compression device has non-elastic Velcro straps that provide sustained compression. It's easy to apply. It is expensive, so it is, but it's a one-time cost. They don't have to replace it. But there's also the patient has to be adherent to it, otherwise it won't work. There's an example of a Circ8. Tubular bandages off the shelf, they allow for graduated compression. They don't accommodate all patients. They lose shape and compression in a pretty short period of time. So usually they're for much lighter compressions. This is an example of a tubular bandage.
A tubular bandage, such as Tubigrip, is an off-the-shelf sleeve available in several widths and compressions. Tubular bandages combine therapeutic compression with ease of application and can be used over a thin primary wound dressing.
Okay. Compression garments are when you're looking at long-term management. You can get both off the shelf and custom garments. Again, we talked about circumferential measurements as we were measuring for custom garments. Um, Usually you only have to go to the knee. You don't have to go to the thigh. Generally, if you can get the fluid moved to the knee, then if that's enough to get it into the larger venous system and move on out. Most garments go for anywhere from 20 to 55 millimeters of mercury at the ankle. You want to use the lowest effective level of compression possible, okay? You don't want to go high if they don't need it, because the more compression you have, the more uncomfortable it may be for the patient. The white socks that you see in the hospitals all the time and sometimes in nursing homes, the anti-embolism socks should only be for non-ambulatory patients. There is a lot of times you'll see them on people who have just had a total knee replacement or joint replacement. You'll still see them walking around with the anti-embolism socks on, but they should only be for non-ambulatory patients. These are examples of off-the-shelf compression. So the one on the left is this one. Let's see if I can get this. This one is 40 milligrams of mercury compression. The second one can be used with a thin wound dressing if you've got an ulcer going on, and this one only creates about 10 millimeters of mercury. This is 30. This is 40, and then this one's 10. This is the anti-embolism socks that I talked about, which are much lighter in their compression. They may have to have aides to help put them on. They have to wear the garments at all times except while they're sleeping and bathing. And they do need to be replaced every 3 to 6 months. Unlike the circ aid does not have to be replaced, but compression garments do because they lose their compressive nature. Jobst ulcer care garments can be used with in combination with a moisture retentive dressing. So Jobst is just one of the name brands of compression garments. There's a donning frame on the left. There's a sock aid on the right, and these both are things that help the patient to put on these compression garments, which can be very difficult to put on, because again, the strength of the compression is pretty high. Here's the compression class and the compression level and when you need to use them. We talked about this in general, 40 to 50, and anything above 50, you really need to have a physician's order. For anything over 30, so 30 to 40, 40 to 50, you really need to have a physician's order. Vasopneumatic compression devices is a sleeve that goes over the extremities, attaches to the pump, and then sequentially fills and empties. You don't really see these used a whole lot in clinical practice anymore. You used to see them a lot, but their efficacy, the research has shown that their efficacy is not as good as it was thought to be. And then there's therapeutic exercise, range of motion, aerobic exercise, gait mobility, anything to get that muscle pump going. The medical and surgical interventions you can see are a duplex ultrasonogram, where they're using ultrasound to really look at the venous system. There's venographs, and then there's also Doppler studies. The medical interventions, they want to manage risk factors for if there's cardiovascular disease, obesity, or diabetes. There are pharmacological interventions, topical agents, antimicrobials, and steroids, fibrolytics, where they can break down that hemosiderin that's pooling in there, and then antibiotics. Surgical interventions would be like debridement, or if they did skin grafting with skin substitutes. And then there's also the venous surgery I talked about, where they actually strip the veins, which means they go in and open them up. You can do ligation, which is where they kind of cut the veins. The sclerotherapy, will help to reroute the veins, and then there's a couple of other surgical interventions here.